This is your regional emergency medical services appendices, and here we're gonna look at needle decompression. So in the protocols, if you notice, right, they give you two possible leg marks. They give you second intercostal space, mid-clavicular line, and they give you fifth intercostal space, anterior axillary line. We're gonna go through how to find them. We're gonna start with second intercostal space first, and I'm gonna go proceed to this one. Very, very important, what you see here, it says, to do this procedure for an adult person, you need a 14 gauge, 3 1/4, right, length of the catheter. So here I have the appropriate catheter. This is an appropriate catheter, and this is not an appropriate catheter, right? So this one is actually, they say 2.25 millimeters. So the length of it, 32 millimeters in length. This is not long enough. I'll show you how this looks. So then when you're on the ambulance, right, and you are looking at this, right, you see the difference? This is the appropriate size, this is inappropriate size. Why would this may be inappropriate?
It will not reach?
Yeah, so for those patients who are obese or have large muscle mass, right, big chest, you may not be penetrating, right, in the pleural space with this catheter, right? And you need this one, right? So as long as you're clear, right, and the appendices tells you that. So once we identify this, I have a sharps container here, but we're not going to sharps it because we're going to reuse this. This is ARS brand. So even though your protocol says, right, the intercostal space and all this, if you're going to use a specific brand, you have to look at the manufacturer's instruction, right? Make sense? Just want to point something to you here that many of you probably don't know, right? So this is the brand ARS. They tell you the length of it, but what I want to point your attention to is here, right? They tell you in this part, right? The reason why we're placing in this location is that we want to make sure we avoid any structures in the mediastinum, like the heart, the great vessels, right? And here they say they want you to actually insert through the chest wall, right? And you want to make sure you are lateral. So it says here, right? You want to go through the anterior chest wall lateral to the mid-clavicular line. So what does lateral mean? To the side, right? To the side. On this mannequin, you notice all of them are basically placed exactly where the sternum is, right? So what's the problem with that? I'll show you the diagram so that you guys can see, right? Right, so this is a good picture here, right? You notice, right? Here's all the great vessels. So if I'm putting it right by the sternum, what can I damage?
The great vessels.
The great vessels, right? So you could cause bleeding, right, to the person, internal bleeding, internal hemorrhage. So just to make sure, mid-clavicular, so this is the clavicle, you see where it extends to? And mid-clavicular line will be here. And you want to be lateral, right, to it. And we're going to go to where? Second intercostal space, right? So this is where my finger is pointing at. This is your first intercostal space. So how would you locate it? If you find your sternum, right, you find your sternal notch, go right away down here. This is your first intercostal space, right here. One more down from it, this is your second intercostal space, right? And you're going to go lateral, away from the midline, right? So sternal notch, right? First intercostal space, palpate. Second intercostal space, I'm going to move way to the side to avoid any structures. Everybody see that? All right. So the way this procedure is going to be commenced, right? Usually, what you want to get into a habit, carry like a Sharpie with you, so you can mark, right, the location once you palpate, because we're going to clean the site once we do that, right? What you want to have your gloves on, so I have gloves here, and you want to have your face eye protection. Why? Because sometimes, well, not sometimes, when you have tension pneumothorax, there's pressure inside the thorax, right? There's high pressure. So what may happen is you may get, it may go into your face. So you want eye protection, face protection, and you want definitely gloves for this. Just to show you, right? We do this procedure specifically for tension pneumothorax. What's the difference between tension pneumothorax and regular pneumothorax?
Pressure,
right? Causing what?
a shift into the heart.
So let me show you guys. Let me show you this guy. Right, so we don't do this just for regular pneumothorax. You see all this? This is black space, right? This is air, and you see how this is the heart. The heart should be like here, right? But you see how it's deviated? They have an endotracheal tube in the trachea, right? And it's right here, right? And everything is shifted over here. The lung is actually this portion here, and all this is airspace. So this is tension pneumothorax. This is why we do this procedure when we do this for regular pneumothorax. So some of the signs that you're going to find on your patient is absent sounds on the affected side. So let's say, since I have this mannequin positioned this way, we're gonna say this side, the patient's left side, right? This is the affected side. And we're gonna have absent lung sounds. You're gonna see probably tachycardia, tachypnea develop, right? They're gonna be hypoxia there. Are you gonna see tracheal deviation?
Late signs.
Yeah, probably not gonna see,
No,
right?
like that.
So you will have tracheal deviation contralateral to the affected side, but it's a late sign, right? You're not gonna see it. So what you're gonna go by, auscultate mid-axillary, right? You have absent lung sounds, right? You have tachypnea, hypoxia, right? Tachycardia on the patient. And you may also determine, right, jugular venous distension, JVD. Why? Because the cable system is under pressure, right? It cannot drain from the jugular vein. So no flow, you may see JVD. However, if they lost a lot of blood, you may not see that. And then, right, when are we gonna do this procedure? In a primary assessment or a secondary assessment?
Primary.
Primary, right?
It's life threat.
The moment you determine, right, absent lung sounds, hypoxia, tachycardia, you feel maybe no radial pulse, he's cool pale, diaphoretic, signs of shock, jugular venous distension, right? May not see tracheal deviation, right? So I have the signs and symptoms. I'm going to needle decompress. I'm going to use the 3 1/4, right? And what I usually do, for this manufacturer, they'll say go straight ahead. I don't personally like to do that. I'll take a saline, right, and I'll dump some of it from my syringe. So let's say this was a 10 cc saline. I'll dump some of it and I'll connect my syringe here. So here there's actually saline. Why do I do that? As I penetrate through the chest wall, the moment I go through the chest, the actual fat muscle, right, and I'm in the pleural space, I'll see air bubble starts to come up. So I know I stop my advancement. If you do it without it, you could do it, but I just find it, and you have something to hold on to, right? And then, as I said, right, there's 2 ways of cleaning it. You have chlorhexidine prep, which is this one, right? You might see this, right? They crack it, and then they cleanse. If you don't have this, you can use alcohol. I would first find the landmarks, and the way, as we said, right? So sternal notch, this would be the first intercostal space, right? And going down, this is the second. You see all the stab marks here? This is not where you're placing your syringes, right? You're gonna go lateral to it, and then I would mark my site so that I don't lose it. Concentric circles. If you had betadine, chlorhexidine, right? And then I connect it like so. Saline is here, right? I keep the skin taut, and this would be my mark. I go 90-degree angle at second intercostal space, and as I'm advancing, I'm pulling back on the plunger to the point that I want to see the air go through it, right? So I was in the wrong location. That's what you get for not marking it, right? So
It happens.
as you go in, you pull back on the plug. See, now it's ease of advancement, right? So you should have air bubbles. What I will do is, at this point, I disconnect my syringe and it will air vent, right? Because I penetrated, and then what you're gonna do is you're gonna advance your catheter all the way, right, for the hub to be on the chest. This goes in a sharps container. Don't actually throw this out. We're gonna reuse this ARS device. Everybody follow? So just put it on the table. You should see, right, or hear air escaping, and you should see dramatic improvement in hemodynamic status of your patient. So what of the things you may anticipate seeing?
Blood pressure will go up.
Yeah, blood pressure may go up, but we may see resolution of JVD. We may see a little better excursion of the chest, right? And
Is it oxygen saturation?
that might come later, right? But we see, right, patients may have an easier time of moving the chest wall now. What you did is you took a closed tension pneumothorax and you now convert it to an open pneumothorax, right? So what's the problem with this?
Infection.
Well, you may get it, but before you get to the infection stage, what will be a problem with this now?
Clotting.
So the problem was this, right? Now you have atmospheric pressure from the outside and inside now equal, because you have a connection here, right? So even after you've done this, you must be always cognizant for this to clot or for the muscles to spasm to occlude the catheter. So you may have, again, tension pneumothorax developing, right? And what you're gonna do if you have, again, jugular venous distension, right? Absent lung sounds and so forth. You're gonna take another ARS device, right? So I have it here, and you're gonna place next to it, right? Don't take it off, don't kink it, right? You're just gonna, again, do the same procedure right next to it. Make sense?
How many times can you do it?
As many times until you get them to the hospital if you have, again, right, development of tension pneumothorax. All right. The other device, so any questions about the landmarks and how to locate it, right? I'm gonna leave this one here. I'm gonna show you, what's up? Oh yeah, that's right. I came here for exactly this reason, Bob.
Okay.
So what Bob is saying, right? So when you're placing this in, second intercostal space, right? You're gonna go right above the rib, right? Above the third rib, not below the second rib. Why is that important?
Because the bundle of the vessel and nerves are under the second.
So you have this. First of all, you have these arteries, right, that supply your chest wall and thoracic internal arteries, and you see how they are, right? If you go right where the second rib is, you could actually penetrate them. So you go right above the third rib when you're going to be placing it. You're avoiding these vessels and the nerve bundles, right? Neurovascular bundle with the actual arteries. So right above the third rib, right? Not below the second rib. Everybody follow? So second intercostal space right above the third rib to avoid neurovascular bundles and the arteries. The other one, I'm going to show you, the other landmark, I'll show you how to locate it. I think it's easier to see from the video. This was from when they placed the chest tube, but the doctor there shows really good landmarks. So I think it's good to see. This one.
The xiphoid process should be used as a landmark. If the curvature of the ribs is followed around the chest wall from the level of the xiphoid, this action typically approximates the fifth interspace. The first rib joins the sternum
Right,
just
so I'm
below
going
the
to
clavicle.
pull back.
Should be used as a fifth rib for landmarks during the actual insertion of the tube. In the male, typically the nipple is found between the fourth and fifth rib, and moving lateral will approximate the fourth or fifth interspace. In the female with pendulous breast, the nipple is displaced downward, and therefore the xiphoid process should be used as a landmark. If the curvature of the ribs is followed around the chest wall from the level of the xiphoid, this action typically approximates the fifth interspace.
All right, so this was basically for insertion of the chest tube, but they show you pretty good, right? How would you do it, right? So on the female, right, you're not going to go by the nipples. So what they say, go by the landmark. So you find the xiphoid, and then the curvature, right, of the ribs. You're basically going to outline this, and then for the male, they said it roughly corresponds to where their nipple is for the, right, fifth intercostal space, right? So you're going to go here. Anterior axillary line is my arm is straight down, right? This would be mid-axillary, so anterior axillary is right where my arm is in front, right in front of it. So again, xiphoid, and you're going to go here. Now, what are some of the problems in terms of these sites? What is as opposed to this site?
The heart, you could.
Yeah, you could essentially, so like you see I'm on the left side, right? The apex of the heart is pointing this way, so you could essentially, you see, let me show you. You could essentially penetrate the tissues there if I'm going to go, right? The catheter is very big, so it becomes even more vital, right? So as you're inserting it, right, it becomes even more vital to make sure you aspirate right. Right? If you don't aspirate right, you see how big this catheter is? I can essentially penetrate the heart, and then you're causing complications, right? So ideally, you want to start with the second intercostal space. This is what this manufacturer also recommends. They say third intercostal, but we're going to go by your protocols. So start here, and if you have no resolution of the pneumothorax, then you're going to go with the alternate side, right? So again, xiphoid, make your way around, right? And you're going to find it here, right, by the nipple on the male. So second intercostal space, and we already talked about it. What else is important about this procedure?
That the catheter rolling is fully advanced.
So the catheter will stay in place. Are we gonna? So are you guys gonna secure it in place? Is it essential to secure it? I would say probably not. Even the manufacturer shows, right? A lot of times when they did this in the war setting, right? You will see soldiers brought into the OR, right? They'll have like 2 or 3 of them, right? Like next to each other, and they let them being open, because what you're basically doing is taking a closed pneumothorax, tension pneumothorax, making it into open pneumothorax, right? But make sure you're always checking for the development of tension again. If that occurs, right, you're gonna drop a catheter right next to it, right? Sometimes you may have a patient who has, in a traumatic arrest, and he has penetrating injuries. Oftentimes, bilaterally, you decompress. Oftentimes, right? Because they're already in cardiac arrest. They could have tension pneumothorax on both sides. You auscultate long sounds and you're not hearing anything, right? And then you do it. Another very, very important, right? You determine your patient has a pneumothorax, right? And they're not really breathing well. Do we want a positive pressure ventilate them before we decompress?
No.
No.
How come?
You could give them an emboli.
not emboli.
You're gonna give more
Pressure
pressure to
makes
the.
it
Yeah,
worse.
exactly.
You're gonna give more pressure,
basically
and you're not gonna.
exactly.
You're gonna
So
continue to
so you are think of it like this. There was a penetrating injury, and maybe the chest wall sealed off or the muscle spasm. You have no more communication. So when I take a breath in, my lung is punctured, so air is coming in, causing that right shift and tension, and then I start to positive pressure back in. I'm going to put more air. I'm going to train more air. So you're going to drop them again, hemodynamic drop, right? You're going to drop their cardiac output. You're going to see again, right, development of jugular venous distension and all that. So what you can do in those settings, throw another breather on them and decompress, right? And you could decompress bilaterally for those patients. Traumatic arrest, right? Penetrating injury to the thorax. Can you have a pneumothorax with non-penetrating injuries?
Yeah.
Yeah, right? How?
Question.
Crush injuries you could have, right? One of the ribs breaks off and it punctures one of the lungs, right? And then sometimes you may see, right, in a nursing facility, right, it could be secondary to like a disease process like COPD, maybe their bulla, like some airspace ruptures, right? And from the lung parenchyma, air is getting trained, they're on the ventilator, more air is coming in, you arrive to the facility, you'll see that. What I see in the OR, right, patients post-cardiac surgery, when they do like open surgery, they put chest tubes on them. And those chest tubes get clotted, and I oftentimes see subcutaneous emphysema. One of the side, like you will see, like it will balloon up, like no other, like so big. You compress it, like literally like Rice Krispies, like you feel the air through it. And one of the they study the draining and doesn't take away air, so you'll see subcutaneous emphysema develop with those patients as well. So always be on the lookout, right? And just side note, right? If you have patients who you're transporting on a chest tube, right, who had pneumothorax and they put on a chest tube, and for whatever reason your canister gets dislodged and there's still a chest tube coming out, what is the most important thing to do right away? So you know what I'm talking about, right? You have a patient that had a pneumothorax, they placed the chest tube, there's a tube coming out from the chest, and there's like a pleural vac where it's connected to. So let's say you knock it off or stretcher, right, bumped it and it's disconnected. The fluid leaked out. What are you gonna do with that tube?
Connect it again.
Let's say you cannot reconnect it.
Put your finger on it.
No,
Plug it.
that will cause again tension. So what you do is you open a saline bottle, sterile saline. You know what I'm talking about, right? For like the one used for burns. Put the tube there. So this will create the air bubbles to escape, and it will create water seal chamber.